Well, good evening. We're live on YouTube. I'm Faye D'Souza. Thank you for joining me. The good news is that the cyclone has come and gone and people in Mumbai are okay. We've been spared the worst. In fact, I must tell my audience in complete honesty, this was a conversation we initially planned to have on how the cyclone or the impact of the cyclone would derail or delay the work being done in Mumbai to fight COVID. Thankfully, that is not a conversation we need to have today because there's been very little impact on the ground, and for that, we will always be grateful. So we have to have a second conversation. And the reason why I'm bringing this up is because there have been so many people who've asked this question, and it's a very difficult question to answer. The question is this: should government be easing the lockdown at this point? Now, quite honestly, I'm coming to this particular debate with a completely open mind because I don't know the answer to this question. It is a very difficult question to answer. On one hand, there are those people who are suffering from the lack of employment, who are starving. I've had a conversation with someone who told me that in Delhi, women who used to work as housemaids are now having to beg for food. And that is really a very, very deeply unfortunate thing. So on one hand, you have this need to put people back to work to avoid the kind of pain that we're seeing happen across the country. On the other hand, when we did lock down in the beginning, we were at a few hundred cases. At that point, we felt the need to lock down the entire country. We are now, as of today, 207,000 cases across India. So has the lockdown prevented us from being 20 lakh cases? And if we're easing the lockdown now, does it mean that we're going to go from 2 lakh to 40 lakh cases? What is really the right answer here? To help me answer these questions, I have with me Dr. Sanjeev Mehta, who's the Chief Pulmonologist at Leelavati Hospital, Dr. Shruti Tandan, who is an intensive care specialist who's setting the COVID ICU at Jaslok Hospital in Mumbai, and Ravi Duggal, who is a public health activist. I'm very pleased to have all three of you join us in this conversation. But initially, I just want to put up a chart on your screen to show you how that that line has been moving. Now, we've taken a total of 190 days to reach the first 1 lakh mark from when we first discovered cases in our country. And we first discovered cases in our country on the 30th of January. From there to reach the next, the next 1 lakh happened much, much faster. So May 19th to now the 3rd of June. That's how quickly we reached the 2 lakh mark. And that actually shows us that perhaps, that spike is nowhere near flattening out. And that's really my concern. So just to throw this open to my panelists right now, should the government be opening up at this point? Dr. Shruti Tandan, purely from a medical point of view, and we leave the humanitarian crisis, for a different discussion, but purely from a medical point of view, do you think now is the right time to open this up?
So actually, from a medical perspective, it's definitely not the right time because our cases are on the rise. But I'll tell you what, there is, in addition to the government-imposed lockdown, there is a self-imposed lockdown of the healthcare workers. And I think if the government can do something to ease that and get the healthcare workers back in place, so we can actually rejuvenate the paralyzed health system, get back the actual strength. One of the leading dailies did this piece on the actual bed strength of the hospital. Like Jaslok has 350 beds and we're giving 30 COVID beds. And overall, we're running on less than 100 bed strength. If we even go back to our original numbers and then we can handle these patients, I think that's a good time then to say, yes, okay, we need to start opening a lockdown and allowing people to work with complete precautions and spend the same time in educating people. But from a medical perspective, it is a terrible time to open.
Faye, you're muted. Faye, you're muted.
All right. Sorry, forgive me. My dog's been barking suddenly. So I also want to ask Dr. Mehta this question. Dr. Mehta, if we do open at this point, and here's, the whole argument was when we locked down, when it did happen, the advantage was we didn't see the escalation that we could have seen given the number of people that are in our country, the population density. What is the likelihood of what might have happened? What might happen if with the easing that we're seeing right now?
So if I may seek your indulgence, I like to answer this in a more nuanced and detailed way.
Please.
So I think, Faye, we have been unfortunate. This is just my opinion. Focused on the wrong number. We've been looking at the number of cases. Now, everybody knows that when we have a flu, this is going to affect the entire population till we develop some form of either external immunity in the form of a vaccine or by an injection. So just looking at numbers, and this is, I think, in my personal opinion, restricted testing. If you had more testing, then probably we would be looking at not 2 lakhs, but probably already looking at 5 to 6 lakh patients who have had the virus. So what number we really should be looking at is a death rate or case fatality rate. Now, if you did that, then we are doing extremely well. My own feeling is that we are looking again at wrong numbers. We should be looking, as Dr. Tandan said, at the bed strength. We should be looking at how we are ramped up our testing and treatment facilities. We should be looking at mortality. This number has to go, because in the end, the only way this whole epidemic is going to stop is when we probably hit very large numbers, say 20 crores, 30 crores, before it goes down. And I know people have been abused for using that number but you know what? How am I going to stop this disease till there are enough people who have had that subclinical infection? And I think if we get down to antibody testing, we may begin to see a very large number of patients. But that's not the point. The point is, I think we got to focus on treatment. Second thing is that if we did not open up now, you cannot open up in the monsoons, because in the monsoons, we're going to be hit with lot more infections, which are going to be the dengues, the malarias, and all of that. Now, I think so my answer is that it's time to start ramping up facility. And if you haven't done it in 2 months, then you failed in your thing. Third thing is, lockdown is not going to treat corona, for God's sake. So let's not. So I think a lot of focus has been wrong, looking at the wrong numbers. Treatment of corona is not going to be the lockdown, but actually ramping up treatment facilities. If you did that, I think we are in the right place. It's a summer. Northern India is in summer. This is probably the best time for people to be able to get the exposure. It's going to happen, whatever else happens. And my opinion is, it's time to do. What I really appreciate was initial lockdown. I really appreciate that we're doing a graduated opening. You cannot just go and open full time. But my opinion is it's time to get people back to lives. Otherwise, it may be too late. I tell somebody, you cannot water a plant after it's dead. Many industries are not going to be able to stand on their feet. That being said, I know I'm going to get hit by a lot of patients. But as Shruti said, her hospital is 300 bed, working at 100. My hospital is 300 bed, probably working at 150. So those are a lot of facilities that are available. That should be the focus, not looking at just the case numbers.
Correct. Mr. Duggal also joins us. Mr. Duggal, like the doctor said, that a large number of people are going to get the virus. My concern here is, and I've visited a lot of the hospitals in Mumbai. The public healthcare system is overwhelmed. At least in our big cities, we know that there's a limit to how much our government hospitals, as we call them, can take. If there is a large spike in numbers, can the public healthcare system take it? Because like both the doctors have said, we haven't really ramped up anything.
I have a slightly different take on this lockdown related issue. Whether you open the lockdown now or you don't do it, it really doesn't matter. Because the initial decision for a general lockdown was, I think, an unstudied decision. It was a decision that actually created the crisis further. It converted a public health crisis into a humanitarian crisis. So I think that's the first point I'd like to make. And that happened because there's a certain class character to this whole COVID issue. Initially, the people who brought in the cases were middle and upper middle classes, or upper classes, the rich, and or the elite, what you might say. When so they were locked. I mean, you created quarantine. People were at home. They could afford to be at home. Now you create a full lockdown. It affects the livelihoods of the informal sector workers, which is 80 to 90% of the workforce in this country. So what you were actually doing with the lockdown, you were protecting the rich, and you were putting pressure on the poor. The poor could sustain it for 15, 20 days in April. But then they said, sorry, we can't live on charity. I mean, NGOs were reaching out to them and providing the government was failing utterly. They had food stocks, but they could not reach it. So NGOs in some sense, are civil society organizations, trade unions, other movements, they did a lot to prevent the hunger catastrophe from happening. So now the question that you raise about the overwhelming of or the overburdening of the public health system, yes, that's already happened. But I think there's a lack of political will to take action on the ground. The government, the Maharashtra government also said, and many other state governments said that, okay, let's take over private hospitals. They only made announcements, but they've not done it. The Maharashtra government said 80% beds in each private hospital, in each ward or whatever they take up, but they have not actually taken over. They left it as a voluntary kind of thing that hospitals will provide so many beds, etc. So therefore, the hospitals that provide few beds, Jaslok provides only 30 beds, for example, out of the 350 beds. So I think there's lack of strong decision making, unlike in Kerala, where there's a properly defined system of how you go about engaging with this whole public health issue as well as the humanitarian side of the issue, which is not happening in any other state.
Yes.
A few northeastern states have been able to do that. See, you should also look at, I mean, states which have lower cases, lower death rates, they are states which have good primary health care. So Kerala, Mizoram, Puducherry, Goa, you may say these are small states, but they have managed the crisis very well. Himachal Pradesh, they don't have deaths. To give an international example, I think Mongolia and Vietnam are two outstanding examples which nobody talks about. They took the decision early enough. Mongolia, mid-January, they decided no flights from China. Okay, so they planned it very well. When they got the first case came much later, but they were able to control it. So no deaths in Mongolia, no deaths in Vietnam. So our policymakers, our planners, our so-called experts in the government, they failed us miserably. The task force at the national level, I mean, there are a lot of people who came out of that and said that they were not listening to what the government was and the bureaucracy was deciding on their own without actually consulting the real experts, the epidemiologists, and so on, to look at the public health crisis. And today we are sitting on a humanitarian crisis, which affects the poor more. So we must take over private hospitals in emergency. You take them over till you're able to strengthen the public health system. But I mean, that's the only way out now. If you run short of beds, etc., it has to be that kind of, it's an emergency. Let's face it.
Well, let me bring in the two, private hospital doctors who are part of the conversation at this point. Let me start with Dr. Tandan. Dr. Tandan, this conversation of taking over the beds in private hospitals and then dictating, effectively that means dictating what the private hospital is allowed to charge. And I know that the hospital that you work for has run into some challenges with the government on this matter. Could you tell us what the challenges are on the back end in implementing this idea?
I think the biggest challenge that we are facing now is, and I've been saying this for a long time, so it's kind of repetitive, but the biggest challenge we're facing is manpower. And everybody talks about recruiting doctors, but in the ladder, you're talking about strengthening the top rung. But what about the rest of the foundation? So we have only Badli workers who are coming into the COVID units. There is no full-time housekeeping staff. They're all unionized. When we talk about, I think, Mr. Duggal has raised some very pertinent points. So this whole lockdown has been planned in a hurry. And when we've implemented the Emergency Act and the Epidemic Act, I think one of the things which the government needs to do and should have done a couple of weeks ago is paralyzed unions altogether. So backed by unions, there is no housekeeping, and this is a universal problem across hospitals. There are nurses who are putting in resignations, and there are terrible videos of KEM hospital of nurses who have gone on strike, and there are 3 residents managing 30 critical care patients. So, Faye, at the time when you sent me this invitation to join this, and the Nisarg was outside raging a storm, I actually sent a group invite for a WhatsApp group to ask people if they want to sign up to work as nurses in KEM hospital. My husband said he'll join me, and you'll be surprised. I thought nobody will. But I had 10 people across different groups who signed up in a matter of 2 or 3 hours, and they asked me if they can ask more people. So there are doctors who are willing to go there, who are specialized doctors, willing to go there and sign up to work as nurses, because when we see that video, it frightens us how pathetic it is that there's no one to administer medications. Why does the government not come down on things like this, which have been shouted out from the rooftops, printed in dailies every day? It's very easy to announce and withdraw lockdown. I mean, it's a populistic move. But how about solving the real problems? I mean, here, if you're going to ask me for 80% of my bed strength, I'm running at about 100, 150 beds. So if you ask me for 80% of my bed strength, I will be able to give it to you, but that's not good enough. I have a 50-bedded intensive care unit, but it's demanding more housekeeping, it's demanding more nurses, and it's demanding some external help from engineering services if we want to engineer the way to handle these patients. So creating fancy units at Mahalakshmi Racecourse, etc., doesn't suffice the purpose. Before we started this whole conversation, one of my students reached out to me with the idea that, ma'am, can we ask stable patients to monitor unstable patients? Can you help me make a module to do that? Can you imagine level of desperation that we are getting to? So these are the problems which really need to be sorted rather than, and it's something which has just been going on. I wonder why nobody is listening. I can understand the frustration of the people of the MTF. I mean,
Dr. Mehta?
I completely, totally agree with Dr. Tandan. I think she's hit the nail on the head. In the roundabout way, we've been saying this, but I think she's hit the nail on the head. You have to operationalize the existing beds. And what she said is very pertinent. You've got to get the next level of staff inside. So there are FIRs against doctors if they don't open the clinics. Doctors at this moment are so scared. They're sitting with 3 layers of PPEs in chawls, trying to serve the people. Very good. But why are there no strict measures against staff? Nurses are resigning. I think I said this at your last meeting too. Nurses are resigning. The ward boys are not coming. There are problems in their societies who may not accept them. Be what it may. Why is there no strict action? And there are tons of people. We are running at much less numbers. So I think that's a very important thing. I hope that all 3 of us are saying the same thing. I hope that the people in power are listening. One thing I would like to add at this time, and I know this may be at variance to what Dr. Tandan may be feeling, but I'm looking at numbers from, say, the rest of the world. So let's start by looking at numbers from, say, I'm answering this question about the lockdown. So let's start with, say, Italy. 2 months surge, over, beaches are open. France, 2 months surge, over, beaches are open, everything is open. US, New York now beds are available, 2 months surge. I think the little extra fear that's going on. Right now, beds are available in my hospital, not the ICU beds, and which is what Shruti is talking about. We need to have that level of care, but we have to have it more nuanced. So beds are available. I think Worli opened up. Worli was the first slum to be hit. It's done its herd immunity. It's now not surging. I think the number of cases in Dharavi is going to start to come down. I've been looking at the peak of Maharashtra. Probably on lesser testing, that's coming down. I think it's a 2 to 3 month surge. You've got to hit it now, but address the real issues which everybody's telling you. Get the hospital beds, get the supporting staff. I think that's the way to go. That's my feeling.
absolutely. And see, if you're going to ask us to double the beds now, we're going to compromise on the care. I mean, as such, when the whole crisis started, NHS sent out a circular saying that please accept compromised care. And I would say that we are not able to provide the same level of critical care or hospital care. And I keep telling this to patients who come into the hospital, that mentally prepare yourself. The hospital is not a nice place to be during COVID. Patients who are on ventilator are getting more hospital infections than they would otherwise, because we don't have that kind of nursing staff that we had. And if you're going to further come down, the patients may recover from their COVID pneumonia, but we may lose them to sepsis.
Shruti, to support that, Faye, if I may, I think in USA they have passed a rule that they have stopped any legal action to be taken against doctors. And I'm very scared at this time because we are not able to see. And no, nobody wants to do this deliberately. There may be a bad incident somewhere, but to take the mental trauma away, we can't go in and out of the COVID wards. So the doctors in USA, which is one of the most litigant society, have been told that they would not be entertained. Law cases will not be entertained. And we had a case where, believe you me, we had the gentleman who was unconscious. We were COVID positive, doing day and night care for that individual. But the family, being litigant, wrote a letter to us with copies to the entire administration, including municipality, that I am not being spoken to by the doctors. So this is malpractice and a negligent service, and we'll do a case against you. And for the number of PPEs. I think you need to protect your doctors and please get the right people. I think the message is do the right thing.
Yes.
I couldn't agree more. Yeah.
So I just want to remind our viewers that also on the channel, there is a report that we have just done from Dharavi on the ground as to how the healthcare workers are tackling the challenge in Dharavi, and how while the numbers have not gone down, the rate at which the transmission has gone down. So the doubling rate has come down drastically in Dharavi, and the last I checked, it's at 31 days. Compared to 17 days for the rest of the city. That's an improvement. Yes.
Because the 7th Amendment has changed the rules for testing. The rules for testing are so strict that if you don't fill up the form correctly, or if you fill up the form without examining the patient, then you are liable for license cancellation. I know most people who have refused to test, who have refused to write prescriptions for patients because they're very afraid of their license getting cancelled. So when they're not testing enough, how can we say the doubling rate has come down?
So that's a point, Shruti, isn't it? See, sorry.
Today's newspaper carries an article saying that, I think one of the prominent dailies carries an article saying that now you can test high-risk contacts who are asymptomatic, but there is no such circular available. So that,
Shruti, that's a point. We doctors are at we're getting the bad end of the stick, both sides. If you don't test and the guy comes positive, I will go to jail. If I test, I'll get my license cancelled. What does a doctor do?
So let me bring in Mr. Duggal. And here's a question. So then I'm going to present a new question to the panel. And the question is this: are we misrepresenting the number of cases in India because we're not testing enough? And I know that our testing rate is very, very low. And, that's the rate that has not changed. The government has changed rules. Like, for example, in several states, they are not testing dead bodies that are suspect to have died of COVID. That's really dangerous. Secondly, they're not administering as many tests before releasing someone from quarantine or hospital to see that they are truly, in fact, negative. Mr. Duggal, your question to you, from all of this, would we understand that this number 2 lakh cases that we're looking at today could actually be a lot bigger, a lot higher than this?
Yeah, it is going to go up substantially. But before I get into that, I mean, the question which Shruti raised about the HR crisis, I agree with that. I mean, there is a major HR, human resource crisis, and that crisis has been created by the government. Why are people wanting to resign? It's because of the way doctors, nurses are being treated. I think what we need to do is, as I said, it's an emergency situation. So you need to get private doctors on board. You need to make compulsory public service the norm right now. That's the only way of solving the crisis. You can't, if you get doctors from Kerala, that's not going to help you. Because Kerala does well because of its system, not because of its doctors and
The
nurses.
point is,
Yes,
sir,
doctors,
not only
nurses
doctors,
do
we need
matter.
the staff also on board.
Yeah. So the entire HR staff, I'm talking of HR, human resource, everybody, all the support staff, etc. So you need everybody, but you need to treat them properly. You've been discriminating in providing PPE kits to different categories of staff, etc. So all that is a reality. And the conditions in the hospitals are terrible. You need to improve on that. You can only do that, I mean, if you pump in more resources. You need much, much more resources. You cannot otherwise get away with this kind of issue. So yes, cases are going to increase. That's going to happen because we have still not reached our peak, and that is because largely I would ascribe that to our whole lockdown strategy. If the cases increases, that you're going to see coming up, because migrants have gone to their home states, which are poorer states, which have poor healthcare systems, and it's going to spread. The community spread is going to be huge. Mumbai already has seen a large community spread. Many other states may not be able to handle it. I mean, if Mumbai cannot handle it, I mean, just imagine Bihar, Jharkhand, UP, etc.
Yes.
How they are going to handle this
Yes.
kind of a situation. So yeah, we're going to see a bigger spike in cases.
So,
And
that discriminatory treatment, I'm telling you this, at least I can speak about Jaslok and Leelavati without knowing what's happening at Leelavati, but I can tell you that the class 4 workers are getting the same PPE that the doctors are getting. So there is no discrimination happening amongst them, but it is just a mentality. The same staff get infected in the community and they come back and they expect the hospital to do free treatment because that's in their contract. But how about doing the work which is part of your contract? You can't cut their salaries. You can't hold it back because it's an epidemic act. I mean, why are all the caveats of the epidemic act working against us?
Well, in fact, I must point out to you, Dr. Tandan, that when I visited some of the public hospitals, we met class 4 employees who said that they weren't treated the same way, that they weren't given, for example, in the government hospitals, there were some of them who said they're not being given accommodation, they're being asked to sleep in the corner of the ward, which they believe is not sanitary, it's not safe. So there are challenges on all sides, but you're absolutely right in what you're saying. Let me come back to the testing question. Dr. Mehta, is it likely that our number of 207,000 as of today is an underestimate of what the truth really is?
I think, Faye, but before I come to that, I think I want to agree with Shruti that there is no compromise in care of our class 3, class 4 employees. They get the same PPEs, they're getting full-fledged treatment. We take good care of them. We need to get them back on board. Yeah, I think it's quite likely that my own feeling is we are not only India, across the world, the actual number of infected people are going to be higher for the following reasons. I don't think there are unlimited facilities for testing. So you just physically cannot test the sheer number of people anywhere in the world. So I think that's one. Second, there's a lot of fallacy in the test itself. I'll give you an example. So the test itself is only 70% sensitive. That means the test itself is missing 30% of the population, right? Third, it has to be done in the first week of the infection. So there could be a person who had a fever. At the 10th day, he now goes for testing, he may show negative. So there are fallacies built into the test. There are fallacies of the timing of the test. And there is under-resourced testing. With all of this, and the fact that the numbers are coming down in very high hit areas, for example, New York, and I think in many other parts. So I think the number of people out in the community are much more than we are actually reporting by this. And which is again coming back to my original opening statement, stop looking at the number of cases.
Stop looking at the number of cases. All right.
Yeah,
Dr.
I mean,
Dr.
it's just
Tandan,
scary. I think it's fake. I think it's just fake fear.
Okay. So I want to add something to this, Faye, that see, we are not testing asymptomatics. So we've changed our testing policy. We have put the fear of license cancellation into doctors. So people are very hesitant to write prescriptions for testing. So we are definitely under testing. Apart from that, we are discharging patients without a negative report if they have no fever for 3 days or they are without oxygen for 3 days. The only category where we are doing a single test is immunocompromised or patients on ventilator. So therefore, when we are saying patients have recovered, our criteria is not as stringent as what it was earlier. So we are over-reporting the recovered cases. Third, whenever we report a patient who's critically ill and ask for a COVID report, that report invariably takes longer. And the point you brought up about dead bodies not being tested, I think when we talk about mortality, we really need to include the indeterminate deaths in the numerator and then look at the mortality, has it come down?
I agree with that.
And
as regards
these changes,
testing.
one second, Mr. Duggal. Dr. Tandan, the changes in regulation that you just listed. One, the threat of cancelling a license to a doctor who asks for a test which is supposedly not necessary. Two, not testing asymptomatic people, discharging patients without testing them a second time or a third time, and not testing dead bodies. How dangerous is this change in regulation according to you?
So see, doing 2 negative swabs, probably we were not equipped for that kind of testing. And we did realize that there's a lot of asymptomatic viral shedding. But to say that we won't test people at all and that you're afebrile and to compare that data with the present data is comparing apples to oranges. So even if there is a scientific rationale for that, we can't argue and say that our recovery rate has come down because the two groups are not comparable anymore. Okay, now the safety logic behind this is that you're anyway sending them into home quarantine for a week, and they probably will not have viral shedding at the end of that extended 1-week quarantine, which was previously 2 weeks. So we do realize there's a lot of shedding of dead virus and particles in that phase which are not infective. But then we should not be comparing the two groups.
Right, Mr. Duggal, go ahead.
Yeah, what I was saying about the testing thing, I think I definitely agree. We are testing too little. And if you look at the experience of many other countries, I mean, you can't put so many restrictions on testing. I mean, if I feel that I may be developing symptoms, etc., I have a right to get myself tested. And I think we need to expand that base, because otherwise, how do you know what is the prevalence of this disease? You need to expand the testing base. And many countries have actually, once they reach a certain level, say 10,000 cases or something, they've actually ramped up testing to the extent of even doing 1% of the population daily. That's the kind of level. So if Maharashtra is a 12 crore population, then you need to do at least 12 lakh cases every day testing. That's the kind of level of testing you need to do to actually know what is the spread of the disease. And of course, doing a random study of that is absolutely necessary, because somewhere we have to plan for the future, because this is going to become endemic at some point, like H1N1 is going to get endemic. H1N1 every year you have 1,500, 2,000 deaths happening, or 20,000, 25,000 cases every year across the country. So the same thing is going to happen with this also. But we have to get into that kind of testing and expand that testing to a large extent. Only then will we be able to actually epidemiologically try and bring about a control strategy for this. Otherwise, it's not going to work.
So if I just put this in a nutshell and ask you if I've understood this correctly, effectively what all three of you is saying is this: is business of lockdown, no lockdown, let's allow public transport, let's allow restaurants, this, that, whatever it is. None of it matters unless we're able to beef up the support staff and strengthen and empower the doctors on the ground, both public and private, unless we're able to provide enough testing across the board, across the population, and unless we're able to actually provide all of the equipment that we need medically on the ground. Is that true?
Yes, I think, like I said earlier, remove this involuntary healthcare lockdown first, and then remove the other lockdown. That should be our mantra.
What is the involuntary healthcare lockdown, in your opinion?
The healthcare workers have self-imposed a lockdown, no? Either they resigned or they are sitting at home and waiting to get infected and come to the hospitals to get treated. All are unionized, sitting at home. So you'll be surprised, but one of the hospitals where I practice, the insurance clerks are not reporting to work. So the hospital can't process TPA.
Mm.
It's as silly as that. I mean, after all, they're all members of a team.
I don't agree with that. I mean, there is no self-imposed kind of lockdown of health workers. I mean, look at it from the perspective of those health workers. I think that is important. Okay, so there is discrimination happening. You may not see it in Jaslok, but it's definitely happening in KEM or other public institutions or other hospitals.
If it's not happening at Jaslok, then why should my healthcare workers not come there? And why should I not have the benefit of running 350 beds?
So there is something you need to investigate. There's something, I mean, something which from your perspective, you're not seeing, but see it from the other health perspective, from the perspective of the other staff. Because we've got a lot of nurses reporting to the nursing union from Jaslok also. I mean, we have a network. I'm part of the Jan Swasthya Abhiyan network, and we have nurses telling us the kind of conditions which are there in Jaslok or the treatment that they are receiving, or in other private hospitals also, not only in public hospitals. Yes, public hospitals are bad, but
okay, all right. So, this will actually depend on each hospital, but I have a few questions I'd like to answer. Devyan Banerjee has said, this is a question to all panelists. When can we expect a vaccine realistically? And what he means is a very good question. He's not just talking about the vaccine being approved and available, manufactured for the rich or the privileged, but a vaccine that can actually protect a large number of people in our country. When do you think that might actually happen? Dr. Mehta?
Okay, I wish I had a crystal ball. And I'll answer, then I could tell you when it will be available. The reality is, so let me answer this in a couple of parts. First is, the reality is, at the moment, we are not so sure, as any vaccine normally takes 1.5 years at least. It has to go through the process of, first of all, being in principle working, then demonstrated to be safe, then demonstrated to be effective in the population, then go into production. And that's why everybody is talking about a 1.5 year timeline. I know people are fast tracking it, but I want people, so the hope is that we'll have something in 3 to 6 months time. But I want to warn everybody who's hanging on to the vaccine thing that please remember, with all of this kind of testing, we yet don't have an HIV vaccine. And this is now 20 to 30 years. Flu mutates every year. So even though we had a flu vaccine, everybody in the Western world has been taking the flu vaccine for the last 20 years. We got badly hit by this virus. So I was going to actually throw a googly to my other panelists. What do you think about the second wave? Will it be the same, or will it be milder, or will it be worse? We don't know. We don't know how the virus is going to behave. So we think we have a vaccine. We may have a vaccine in 6 months. I do not know how effective it will be. I'm sure we'll have a vaccine in 6 months because everybody is fast tracking it. They're going to produce a vaccine in 6 months. I'm very sure about it. It's a probably $50 billion game. The Chinese are running for it. The Americans are running for it. The Australians are running for it. Indians are trying it. I'm sure in 6 months, there will be a $10 billion vaccine. The question is, how effective will it be? Whether it will be the same everywhere, whether it is going to be effective next year, because the virus may say, oh, you know what, let me play a googly, let me change. In which case, all of this may change. So that's a more...
yeah, exactly. I mean,
So actually, Mr. Duggal, before you answer that, if I may ask you one more question, the truth is also that in India, I mean, around the world as well, but also in India specifically, we haven't been doing enough R&D to answer the questions of what's the behavior of this virus in India. For example, we're still guessing about why so many of our patients, our positive patients, are asymptomatic. We're still guessing about our mortality rate. We're still guessing about how this virus is behaving with people with comorbidities. Can we see a pattern? Can we see a pattern in weather? Can we see we don't know any of these things. Also then to pick up where Dr. Mehta left off in terms of what it's going to morph into, do you believe we are spending enough time and energy on R&D?
No, we are not. I mean, I think we need to do a lot of research. I don't know, maybe the research institutes are already working on that, and we may get to see something sooner or later. We don't know about that. But unlike the West, I think our scientists need to work much harder and do much more research as to the different dimensions of that, including social science research, not only medical research. But about the vaccine issue, I mean, I agree. The vaccine doesn't make sense. I mean, it's basically a business proposition. We have seen the H1N1 vaccine fail miserably. I mean, in 6 months' time, you don't know whether you'll have to take another shot. So that's the kind of thing. So I don't think I'm looking at the vaccine as a solution. Probably, if it spreads adequately enough, herd immunity may protect us to some extent. But this is also debatable. I mean, I'm not a medical doctor, so I really can't comment on that. But yeah,
Sure.
I mean, vaccine is not
Doctor,
a solution. Definitely
yes.
not.
Dr. Tandan, this idea that 80% or so of our cases are asymptomatic, and so if we do see a surge and a spread, it won't really hurt that much. Is that a fair? Are you comfortable with that theory and that argument?
So if you talk about a second wave with the 80%, I'm not sure because even this whole idea about the vaccine and the second wave. There's a lot of food for thought. We are seeing reinfections. I don't know about Dr. Mehta, but in my hospital and at Bombay Hospital, where my husband practices, we've both seen at least a couple of patients who are actually our own staff, which is why we follow them up, and we've realized that they've got infected twice. So, and the first time they were asymptomatic, second time they've been symptomatic. So it's really not following the trends of what we expect. So the original coronavirus, the SARS-CoV-1, or the coronavirus, which actually causes a common cold, is known to have a protective immunity, and the antibody levels stay high for as long as 3 years, after which they start declining. Now, a lot of these people, at least the ones in my hospital, I did them on a card test and they're IgG negative, which means that they don't have immunoglobulins after the 3 weeks after the first infection, and they've caught a second infection. So I'm really concerned where this will end.
Wow, that's actually, I mean, for our audience who might have missed that, let me do a recap before I take this to Dr. Mehta. But Dr. Tandan is saying that she's seen in her hospital among the staff a couple of cases where someone got the virus, was asymptomatic, which is what we consider a good scenario, tested negative for it, caught it again, and this time they weren't asymptomatic. It took a larger toll on their bodies. And this perhaps is a question we need to answer with the research and development we were talking about earlier. We need to know how this thing is behaving, because as it has been proven in different parts of the world, it actually behaves differently among different races of people or among different geographic locations. We don't even know that yet. Dr. Mehta, have you also seen reinfections?
No, so we haven't, but I think Dr. Tandan makes a very good point. These were people who were in the staff. So she was able to follow them and they came back to her. We haven't seen that, Shruti. My question to you would be, were these people who, had the virus all along, which never really went away, and then continued to show the progress? Either way, it's scary because, that means
the first infection was at the time of the fifth testing circular, the fifth testing guidelines. So we actually had 2 negative swabs. And I agree with you. We had one patient at my hospital. My husband then the other day mentioned another one. And there's another intensive care colleague who I met on a webinar, and we had a casual conversation before that. And he said, Shruti, when I'm seeing it, it's not uncommon. So we don't have answers to these yet.
So there was a big 100-case series from Korea, which they had reinfection. And the question always was whether it's a testing. So, that's a big concern. Coming back to your original point, Faye, which you were making, and Mr. Duggal was talking about, and Dr. Tandan, there's a lot of questions that needs to be answered. I think we are yet in the phase of putting out the fire. We haven't yet got down to the root of the fire yet. Is our Indian strain different from the American strain? Is that different from the original Wuhan strain? What is the actual, molecular behavior of this virus? I think this is an epidemic that has really bashed us. We need to put far more resources at the scientific level, at the government level.
Yeah, sorry to interrupt, but I don't even know if the strain we are seeing now in the past 4 weeks is different from the strain that we started off with 9 weeks ago.
Yeah, I think we need far more virological support. I
Interview earlier, but the patients who we started off with 70 days ago, they were very easy to ventilate. Their only problem was low oxygen, and literally in a couple of days of ventilation, we would decide that okay, it's time to get the ventilator off. So it was a running joke that the blood gas done within 12 hours would tell us it's time to start planning to get the ventilator off. But the last 5 weeks, we have seen very sick patients who are needing longer ventilation. The average length of stay in the hospital has now gone up to 4 weeks. And it is also not allowing us to discharge them at that early as we were doing earlier. And which makes me think that is it just increased viral load, which seems unlikely because they're all getting it from the community. They're not healthcare workers. Or is it just a new strain? So yes, I would agree. We need a lot of R&D to go into this.
Right. And like it's been pointed out, there isn't enough. We don't have enough answers as to what is really going on the ground. Mr. Duggal, is this a lack of funding, a lack of political, motivation? Because let's be honest, it's very easy. It's not easy, but it's easier to bring in a lockdown and take off a lockdown. But to do the R&D, to actually roll up your sleeves and improve conditions in hospitals, to solve problems on the ground, it takes a lot longer. Are we missing the political will, or is it just that our governments just don't know how to handle this problem?
I think it's both. I mean, at one level, the political will is not in the right place. I mean, where it should be in terms of providing services and benefits to people. So that is very clearly visible. And in order to do that, you need the resources. I mean, we spend 1% of our GDP on healthcare. It is not adequate. I mean, if you look at some of the states in India which do well, they're spending 2 to 3% of the gross state domestic product on healthcare. That is why they're able to contain it much better. Okay, again, I'll go back to states like Mizoram, etc., which are doing well, and they spend enough. They take care of the population where health is concerned. The public health systems are quite robust. There's no private sector, incidentally, in many of those states, and I think private health sector is part of the problem. Also.
Mr. Duggal, one thing which needs to come in here is to incentivize the salaries of the nurses and the class 4 workers.
Definitely.
Which is not happening. In fact, we are giving 30% salary reduction to residents. Who, if you believe that video of KEM hospital which is being circulated, there are 3 residents looking after 30 critically ill patients and doing the job of the housekeeping and the nurses.
Yeah, they're grossly underpaid. I mean, I agree with that, absolutely. I mean,
overworked. Underpaid and overworked.
Yes.
Look at the Maharashtra government. The doctors they're bringing in from Kerala, they're paying them much more than what they pay doctors in Maharashtra.
Mr. Duggal, tell me, why would anybody make their child a doctor after this?
Yes.
I mean, I don't know. I mean, it's you could say that's the same thing for engineers or for whatever. I mean,
yeah, but I want to bring in a point that, it's a lot to do with the attitude of the person. So Faye has been to Jaslok. She's seen the motivation of some of the nurses and the doctors. And when I heard some of their stories, I was in tears. We've had doctors who have children who have suffered. There's one of the boys in our team I didn't tell you about, Faye. I learned about this after your interview. His child had meningitis. The child was 3 weeks old. This boy didn't tell any of us because it would mean going home in the lockdown. He said, there's somebody looking after my child. I need to look after these patients. By God's grace, that child is fine and healthy. At this point of time, to complain about the food that you're getting and not getting hot water to drink and complaining about living conditions. So nobody's asking them to sleep in a corner of the ward. But there is only a limit to what you can provide. It's a lockdown. It's an epidemic. I have patients and their relatives doing video calls where the relatives are telling patients ki ye hospital hai, hotel nahi hai, jo mil raha hai prasad samajh ke kha lo. The general public is also rising to the occasion. Why are our healthcare workers, predominantly a housekeeping, not realizing that? And what about the poor Badli worker? Isn't he being given the same conditions just because he's not part of a 5-letter word union? He's supposed to work there because one day his job will become permanent. This is something the government needs to take up seriously. I mean, just because the unions have backing of political parties, they are not doing anything about it. Because doctors are easy targets. We will not stand up. What is the response of that nurses going on strike? That I have 10 doctors who've signed up to say, okay, we will come with you, Dr. Shruti, and we will do 6-hour shifts to help those nurses to dispense medicines. That is the conscience that people have. And are we trying to say that, it's because of differential treatment? When I plan to do this, we are going to take our own PPE and go because we don't know what we'll get in KEM. We don't even know if we will be welcome there. Because there are politicians there who are now denying that the nurses are on strike, denying that that video is false. But I belong to that hospital and I have confirmed that this news is true. I belong to that hospital as a student.
Well, I do want to ask you all this one question of if you were to at this point reach out to government, whether state or center, and obviously these are things being run by state governments, what is the priority? And if we are going to open up, and that seems like an inevitability at this point, what is the priority from the medical fraternity that governments need to ready immediately? Dr. Mehta?
Thanks, Faye. I think we've been saying this through the program. The thread is common between all of us, and especially Dr. Tandan and myself. We need to improve the healthcare system, starting from we need better support from nurses. We need better support from the ward staff. We need more people in, say, offices. That will increase our efficiency. So using the existing beds, this is a far more cost-effective way rather than putting up a new hospital and then everybody running helter-skelter. So our quality will improve at far less cost. So the most important thing is improve the efficiency of your existing hospitals, and that includes government hospitals and private hospitals. And don't give private hospitals step motherly treatment. I think that's priority number one. Priority number two is you need to get the message out. You know what Shruti was saying, but I think there's a lot of self-imposed lockdown. If you ask my friends, nobody's going to go out in a hurry because everybody's scared. Increase the awareness, increase the need for masking rather than bringing in a very wide sweeping lockdown. I think those in my mind. And the third would be, please invest in healthcare. Please invest in the support healthcare. For example, our NIV, National Institute of Virology, needs to be enhanced. We need to enhance the services of, say, the pathology labs. We need to get epidemiologists on board. There is far more than just giving remdesivir to our patients. All this support will help us help the population better. If we have better logistics, better informatics, better support system, that tertiary care of healthcare tier needs to go much stronger for us to be able to give better healthcare. I think those are the few priorities, and gradual opening.
A lot of questions coming in about plasma therapy and if that actually works. If we're talking about the fact that we're not sure about the buildup of antibodies, will the plasma therapy really work? Anyone who wants to answer that question? Dr. Tandan?
Yeah, it's experimental. Okay, there's a lot of excitement about it because, people have used it as a last ditch resort, and then it sounds fancy to go out for somebody and sounds appeasing mentally, that somebody who's recovered. But really, what works is common sense medicine and supportive critical care. So I've been saying this, that when we started off 2.5 months ago, we were just doing supportive care. We did not even know if HCQS is working or no. Those patients were recovering. Today, with drugs like solumedrol and tocilizumab, patients are still recovering. And maybe a few months down the line, I don't think numbers will change with plasma therapy. I think, and just as we're keeping common sense as the center point, the government needs to do the same thing. It needs to keep public interest at the center point and chuck politics out of this. There was a time, I think everything which Dr. Mehta has said, I would agree with in that order. There was a time when not wearing a mask was a punishable offense. Now I see people in my South Bombay neighborhood running around the road, taking their dogs for walks, and there are no masks on. I mean, why should the rules change? Because after all, the people at risk are the police officers, the security guards who are there.
Yes, you're absolutely right. Quick
I think we
question
need to
also
come
to
to
Dr.
some
Mehta
understanding.
about the plasma treatment. Do you believe that there's any stock in that, Dr. Mehta?
I think Shruti has said it very well. It is experimental, not because it's an experiment. It's
Hmm.
experimental because we really need to understand it better. Do which antibodies need to be tested? What is the timing of the administration? What is the dose that needs to be given? It's all up in the air right now. Probably will work, but it needs to be studied scientifically before I can tell you that it is definitely effective. Will it work in some people? Probably will. Will it work in everybody? For that, you need to study it much better.
Okay,
So
Faye, I'm going to give you a very simple answer to this.
Yes.
So the virus is an antigen, so it's like a foreigner, and you attack it with an antibody, which is like a soldier. Okay, so that is what plasma therapy does. But a big problem that happens in COVID is the cytokine storm. So let's say when this whole fighting is happening, jo dhua udta hai na, that is the cytokine storm, and there your soldier is not going to help. So if you have a formed force which comes in from there, it's not going to neutralize the neutralize the cytokine storm, and that is what is killing patients more than this neutralizing antibody protecting the or reducing the viral burden. So,
I
which
would,
is why this
I like to
remains.
add to Shruti. Sorry.
And I know there was a lot of excitement which came out of it when, Mount Sinai in New York said that they're going to give convalescent sera. I have a very close friend who's at an administrative post there. And I got the trial data in. I mean, not the trial data, but the study design in. And the purpose of the study, the aim of the study was not to study if it works, which should have been commonsensical. But the purpose of the study stated there is to administer convalescent sera to sick patients, which is not even testing a hypothesis. So, it's just something fancy which people are coming up with. And there is a lot of, what we say, intellectual dishonesty at this point of time. Everybody wants to shout out something which is different so that they are heard, and not necessarily something which is logical or which is going to work.
Okay.
Can I add something to what
Please.
Shruti said? Yeah. So I think I need to explain to the people, to your audience, that this disease has two very distinct phases. What Shruti was saying was that, there is a viral phase, the viremia, and there is the cytokine storm, which actually causes most of the destruction. All these drugs, whether it is the convalescent plasma, whether it is a remdesivir, whether it is the flavivir, which is now being tried, all work on the viral phase. And so these need to go in the day you make the diagnosis, if it is going to work. So far, none of them have shown to be effective. None of these, probably because we don't know the time. The damage that is really killing the people is supposedly the cytokine storm. And somewhere it's the middle part. The cytokine storm needs a separate set of medications, which is the steroid, the tocilizumab. We really don't know enough yet, but I think as medical science is getting into it, we'll probably be able to learn that better. But the message I want to give to your audience is, don't get carried away just because it is the latest. It does not have to be the best for your patient.
Right. I just want to
Okay.
now wrap this up because we've run out of time, and quickly just tell
Just
our
one
audience where
point.
we just go ahead, Mr. Duggal.
Yeah, basically, I mean, about the question you asked about what the governments need to do, I think I agree with most of what Dr. Mehta said, but basically we need to immediately double the budget for healthcare so that we can handle this much better, so that more investment happens in the health sector. We need to see that all human resources are in place. We have Indian public health standards, so providing all the human resources required, support staff, etc. And I think what I said earlier is that take over private hospitals and bring them into public domain and provide free treatment even in the private hospitals to COVID
I
and
have to do
non-COVID
this.
patients during this period. And that's the only way out. The government will provide the funding for it. So the owners of private hospitals don't have to bother about that. I think this is the time to do it. Some countries have done that actually. They've taken over private hospitals and they're running it.
Effectively, what we're saying when you say take over private hospitals is saying you're saying the
It's a
bill
temporary
should
thing.
be put by the government in those private hospitals.
Exactly.
And
Yeah.
thereby these hospitals then
Don't-
should become accessible to the poor.
Don't put the burden on the patient. who's
Yes.
already kind of cornered out completely.
Okay, so it's now I'm going to wrap this up very quickly. Effectively, obviously, the lockdown easing is inevitable. It's going to happen because the economic price being paid by the country is perhaps too high. But unfortunately, during the period of the lockdown, which should have been used to beef up our testing, to beef up our ventilators, our hospitals, to support the doctors and the healthcare workers on the ground, the nurses on the ground with proper payments, with proper facilities, sourcing PPEs. I can tell you for sure that I still get calls from public government hospitals in Mumbai saying we don't have enough PPEs. Can you raise funds? Can you arrange for PPEs? They shouldn't have to call me. They should get it without asking from government. So this is still happening on the ground. And all of that should have been ready like an army at this point if you are going to ease on the lockdown. Unfortunately, it is not. In most states, it is not. And that is where the problem lies. Because you have a healthcare sector that's creaking under the pressure at this point, you might put more pressure as you ease the lockdown. The healthcare industry is very clear about the fact that it needs help. It needs clarity on testing and better testing regulations. It needs clarity on equipment. It needs help on the ground. It needs help with equipment before and as the lockdown is being eased up. For some reason, governments have not been paying attention to those people who are laying their lives on the line in order to fight COVID. And it's high time the people making the decisions begin to listen to those who are saving lives. Thanks for watching. Good night.